We'll move on to our next session, the management of chronic pain syndromes, fibromyalgia, chronic fatigue syndrome, polymyalgia rheumatica, and the rehabilitation. For this session, I'd like to invite on stage the chairpersons, Dr. Indrani Chatterjee, Professor in Maniktala ESI Hospital, and Professor Dr. Khetra Madhav Das Sir, Vardhaman Medical College and Hospital. I'd like to invite on stage the first speaker for this session, Dr. Debanjan Banerjee, Consultant Psychiatrist, Apollo Hospitals.
Good afternoon. Thanking RehabCon for especially Dr. Kaustav and Dr. Shagnik. I think today among the audience even, I'm chairing Dr. Indrani Chatterjee and my junior colleague Debanjan, who is a very good speaker, are the two persons only from psychiatry. 11:30, I'm seeing that people are really in problem, how the management team will be there. So chronic pain, which is chronic and doesn't cure, is a very agonizing thing and depressing one. So not wasting time, I will invite Debanjan to start to speak and talk on chronic pain.
Yeah, thank you, Indranidhi, and respected chairpersons, and I thank the organizers for having me here. It's always a great experience to be in a multidisciplinary team and meet other colleagues from other specialities, because I was just telling some time back that we as medical professionals, we are tired of speaking about a specialty among our specialities, especially in terms of chronic pain. It's such a thing that, it needs a comprehensive multidisciplinary team approach. Not just about medicines, not just therapy, not just counseling, not just family, but everyone about delirium, something that we, those practice in general hospitals we come across every day. When we talk about pain, of abusing analgesics, sedatives, you will see a lot of individuals. My specialty is geriatric. I see old people mostly. So we see a very high incidence of sedative abuse in individuals who suffer from chronic pain. I mean, every single person coming to me is either on alprazolam or a clonazepam or, a sedative which has been started years back and is continuing in increasing dose. That's because the central tolerance level of pain is often reduced by sedatives. They act on the pain perception, but it's a chronic loop. And it's like in our country especially, we are not sure whether the person will come back to us because there is a huge deal of doctor shopping. They will probably come back to you after a year with a bunch of prescriptions like this, and you really don't know which medicine is going on at what point of time. So there are several aspects to suffering from pain. Of course, loss of work, loss of quality of life, difficulty in mobility, a constant fear, financial drain, multiple investigations. Very rarely does a person get a comprehensive management of not only a chronic pain, but also understanding what are the factors behind it. We used to run a pain clinic back at Nimhans. It used to have a multidisciplinary team from different areas, from neurology, from neuro rehab, from psychiatry, from clinical psychology, social work. And what my personal learnings have been from that is, there is no two persons who will come to you with a similar type of pain tolerance and suffering. And that is independent of the cause of the pain. So every person is dealt with in a different way. I thought since, it's a good forum for discussion, let's present to you a few individuals that I have seen. So this is a 28-year IT professional. Came to our team with ongoing fatigue, myalgia, poor concentration, the typical sensation that, something is not right. And this just 2 months after recovering from flu. We are all suffering now. I mean, something which is very common in Kolkata and around is a flu nowadays. I am still coughing from it. and I'm still facing the same thing probably that this gentleman had faced. A continuous sensation of fatigue and increase in neck, back pain, and I'm not able to put a finger to where the pain is really originating from. He was very high functioning before, now he's anxious, he avoids work, he has health anxiety, he describes himself as unable to focus, and hence he's having difficulty at work. He was diagnosed with post-viral fibromyalgia, possibly also CFS, I'm coming to it later on, and he was treated with low-dose pregabalin, graded activity levels, and he also entered into therapy with a clinical psychologist. After a few sessions and gradually improving his routine, the pain started improving. We all know about fibromyalgia. The terminologies and the diagnostic criteria has changed over a period of time. The ACR 2016 diagnostic criteria is the one which is used now. Previously, we used to have the very well-known figure and the different points of pain on the whole body. Now, of course, there have been changes to it, but most importantly, just the presence of an unexplained pain doesn't make the person either suffering from a psychological condition or fibromyalgia. Fibromyalgia is a diagnosis in itself, and if you look at the last criteria, a diagnosis of fibromyalgia does not exclude the presence of clinically important illnesses. However, let me tell you, and we are increasingly looking at this, it has become very common, especially after any form of flu, viral illness. It rampantly increased in 2020, 2021 after the COVID. These are the points, the pointers of the pain usually. It not only stays limited to pain, it also associated with a brain fog, which is called fibrofog, GI issues, IBS-like symptoms, pelvic floor dysfunction, and very closely mimics lupus, rheumatoid arthritis. In fact, there are individuals with rheumatoid arthritis who have also suffered from fibromyalgia. And they have been just dismissed, telling that you increase the dose of steroids, add steroids, increase the DMRDs, but things have not improved. This is again another very common disabling condition. Myalgic encephalomyelitis. The characteristic feature is post-exertional malaise. You just walk for a few steps and you start having extreme fatigue. To an extent, almost you feel like you cannot breathe. Very commonly associated with clinical depression, again, sore throat, unexplained muscle pain, postural hypotension, and cognitive impairment. Whenever we see somebody little elderly with these type of symptoms, we have to keep in mind that a differential may be geriatric depression. Also, a person who has continuously been on multiple medications, especially beta blockers, anticholinergics, sedatives, SSRIs, can display these kind of symptoms. So what are the reasons when a pain is persisting? By chronic pain, we mean more than 3 to 6 months. But what are the things that we need to keep in mind before we make any treatment change? Emotional distress. If a person has a history of childhood abuse, trauma, it definitely affects their pain perception. Depression, the silent killer. If you actually screen for it, individuals with chronic pain, take it from me, more than 80% will probably have a diagnosis, independent diagnosis of clinical depression. Anxiety disorders, PTSD, analgesic and sedative abuse, addiction. Many individuals who have been long time on alcohol are having withdrawal, cannabis, stimulant abuse. After they stop it, the pain perception goes up. Pain threshold goes down. So many individuals who come to the addiction clinic who have recently left alcohol and are suffering from withdrawal symptoms, they are otherwise stable, but for any kind of pain, they significantly suffer. This is the second case. So 72-year-old retired school teacher presents with lower back, diffuse body pain for 8 months, unrelieved by multiple analgesics, multiple visits to different doctors, not sleeping well, is tearful, hopeless. After almost 7 to 8 months of treatment at different places, the person came to us. And you won't believe, has been on 3 different type of analgesics, takes paracetamol on and off, is on 2 different kind of sedatives, has multiple falls, and the family is still to find what exactly is wrong with her. This is the typical profile of how old age depression looks like. Extreme preoccupation with body. If you remember the movie Piku, significant obsession with motion, constipation, pain. And pain is the major presenting complaint for more than 60% of old age depression. আপনার কি হচ্ছে না ডাক্তার বাবু, কিছুতেই ব্যথা কমছে না, মাথায় ব্যথা, বুকে ব্যথা, পেটে ব্যথা, কোমরে ব্যথা, ওষুধ নিই কমে আবার হয়। And nobody is going to come and tell you I am feeling sad, doctor. And that's what is typical about old age depression. We need to keep our antenna open to understand that if there is unexplained pain going on for a long time and the person is continuously also having affection of sleep, weight loss, the person is not able to function, the antenna should be open for depression. And late life depression is very different from depression in younger age. So excessive preoccupation with body pain, significant anxiety, and excessive dependence on medications. This is again another individual in whose care I was involved, not primarily, but it was a referral. 39-year-old, severe burning pain, swelling and discoloration of left hand following a minor wrist fracture. Despite fracture healing, she reported intense pain, and often it was like, this hand doesn't belong to me. I feel that this hand is out of my body. Increasing irritability, panic, associated depressive symptoms, very common profile for complex regional pain syndrome. Again, this is something in which a multidisciplinary team care is necessary, and all of us who have faced individuals like this, we know that how disabling. I mean, I had 2 of my patients who had attempted suicide because they were not able to tolerate the pain. And pain can be, and in fact chronic pain is an independent risk factor for self-harm and suicide. So again, identifying and bringing the person to care is very important. So a pain physician, psychiatrist, physiotherapist, physiatrist and psychologist were involved. We did start with SSRIs. We started desvenlafaxine, which is a good medication for pain, and associated movements, EMDR based trauma work, that is eye movement desensitization, which helps a lot when an individual has a lot of trauma. Family was involved. Multiple analgesics, going to multiple doctors, multiple investigations, that cycle was stopped, and gradually the person improved. So there are various aspects of complex regional pain syndrome. There are autonomic symptoms, hyperalgesia often, inflammatory features, and definitely a comorbid psychological issues will be there. So what is the role of mood and mind? I started by mentioning this in my title. Any form of chronic pain involves a central sensitization. So if you are sad, you feel pain more. It's as simple as that. How we communicate with the individual, how we involve the family is primary for how the person recovers.
Dr. Banerjee, your time is already up. If you can just sum up. Yeah,
I'm almost done.
Definitely. Thank you.
So integrated management will be very much necessary, and we need to empower the family as well. I won't go too much details into medications, but mostly for chronic pain, TCS, nortriptyline, which has a safer profile, pregabalin, gabapentin, and very low dose quetiapine is used. Opipramol is one of our newer medications, which is a sigma-1 receptor agonist, which is very helpful for chronic fatigue syndrome and fibromyalgia. This is something we use increasingly, palmitoyl ethanolamide, which acts on the endogenous opioids and has anti-inflammatory effect. There are several researches, including a recent guideline of the BAP, which shows that adjunctive use of it besides the other pain medications very helpful in chronic pain. Psychotherapy and involvement of clinical psychologists are often a must if a person is suffering from chronic pain, because cognitive behavioral therapy often helps the person deal with it, process it, and also the pain perception may gradually reduce. So coming to the end of it, I would like to end by these statements that mood disorders often amplify pain perception. How we deal with pain is often important in how we get better from it. Chronic pain often affects a person's identity and self-confidence. Two most important things we need to survive. It affects our purpose. A person starts feeling that I am useless. And there is where the role of rehab and the role of mind becomes so very important. And healing is more than pain reduction. It just doesn't depend on whether you are able to reduce the pain on a visual analog scale using medication. It also means whether you are able to give the person a sense of hope and purpose. So all pain is real, and thanks for involving a specialty in this discussion today, because I guess both of us are incomplete without each other. So let's end with this. Healing is not just about pain relief, it's about reclaiming life's meaning. I personally believe, after really suffering from some of which I discussed today, that the real painkiller is a person's purpose. So thank you, and thanks for having me here.
Thank you very much for your excellent deliberation. It is always difficult to talk on a topic which is less talked about, and you have done that wonderfully. So, is there any question from the audience?
Debanjan, hi, excellent presentation. I just want to know something that as a rehab physician, also working in interventional pain, we do get referrals from psychiatrists for cases like fibromyalgia or CFS, as you said. Sometimes asking whether any intervention can be done to reduce the pain. There might be an actual pain generator. My question to you is, considering this chronic process, do you think this actually helps? Am I doing more harm by temporarily reducing the pain, or is it a right approach? I would just want your opinion on that.
Thank you so much for the question. So, of course, it depends on what the patient wants. Many times, the threshold is crossed, the person is suffering, and the person requests us that, I think it's really gone beyond the point. So can it be reduced to an extent that, let's say, I am functional at least? Because we know that many individuals with chronic pain, they continue working, cooking, going out, playing, but it's there. So when it really crosses a level, I think it's important to involve rehab measures as the referrals that are given to your team, to see so that we can bring it down to a point where the person stays functional. And this gradation often varies. Let's say somebody who is having a fever, or who has had, let's say, a financial loss, or who has probably been down with an illness, automatically the pain which is there in the background may spike up. And then we may need something additional, something extra, mobilization, rehab measures, to see so that it comes back to a level where a person is functional. So I guess this approach is fine, as long as we have this discussion among ourselves and with the patient. Because sometimes, what happens, let's say a chronic pain person, referral is given to us, we go, and when we interview the person and when we say we are from psychiatry, the first reaction is that, why has a psychiatrist been called for pain? And that dialogue is probably important if we really have to heal.
Is there any more question from the audience? If it is not, then thank you very much again, Dr. Banerjee.